Hello, friends. Welcome to Parkinson's EmPower Talks, a journey of empowerment and understanding for living your best life with Parkinson's. Kick back, relax, and get comfortable. We're here to make your Parkinson's journey just a little bit easier. I'm your host, Dacy Reimer. I'm a nurse practitioner specialized in movement disorders and the director of medical advising and education for the Wisconsin Parkinson Association. The Wisconsin Parkinson Association's mission is to provide hope, community, support, and resources for people with Parkinson's and their loved ones. Welcome to Parkinson's EmPower Talks. Today we are talking about memory changes. Is it Parkinson's disease or is it part of normal aging? And my special guest is Dr. Lisa Kokontis. She's a movement disorder specialist and a memory specialist at Neuroscience Group in NINA. She's also a member of the WPA Board of Directors and our chair of our Medical Advisory Committee. Good morning, Dr. Kokontis, and welcome.
Good morning. Thank you.
Give us a little bit more background on you before we get into our topic today. How did you become interested in like movement disorders and memory disorders? And then also, where do you practice?
Yes. I've been born and raised in Iowa. After residency, though, wanted to come back to the Midwest and settled in Wisconsin with a group of neurologists that practice general neurology. And because of the need to take care of Parkinson's patients, I became more and more interested and um, had quite a collection of patients that had Parkinson's disease. And as you know, as you're taking care of people through a long span of their lifetime, dementia is something that can happen. And so you take care of that as with any disorder or disease, you try to improve the quality of life with any symptom that may arise with that condition. Um, and from an offshoot of that, I sort of naturally fell into taking care of patients with Alzheimer's disease, vascular dementia, really any cognitive disorder sort of comes my way.
Mm-hmm. And you actually helped found the memory clinic at Neuroscience Group as well, correct?
One of my partners did, Dr. Giselle Larson.
Okay.
She took it on years before I did. And I'm grateful for her. We are affiliated with the Wisconsin Alzheimer's Institute, and through her efforts, we've been able to continue that relationship, and it's been very fruitful both ways.
Right. So I picked you because I know you are an expert in this area based on your experience with memory clinic. And so tell us a little bit more about kind of what's the difference. Does everybody have memory changes over time? And or is that something that we normally see with age, or is that something that's standard with Parkinson's, that everybody with Parkinson's also has memory changes over time?
Yeah, that's a good question. A lot of thought and research has gone into trying to answer that. And if you take care of people or just do research on older individuals, you will see that there are memory changes or cognitive changes in people as they age. For the most part, when it becomes, quote, abnormal, is when those cognitive changes start to impact their life. Um, in in ways in functioning at their job or socially or physically. And that's actually the diagnosis of dementia is when the cognitive change impacts their life in a significant way.
Mhm.
So not everyone who gets old will dement, but age is certainly a risk factor for dementia. In people who have Parkinson's disease, their risk of dementia is higher than if you didn't have Parkinson's disease. And again, aging with Parkinson's disease is a risk factor. So that if you've had Parkinson's disease for 10 or more years, your risk of dementia of Parkinson's, we call it dementia Parkinson's disease or Parkinson's disease with dementia, increases significantly. Now, the good news is we're living longer, and that's fabulous. But also, the bad news is because we're living longer, we're aging, and we're accumulating more people who develop dementia. Simply, they're living longer and they develop dementia. There are super agers out there. I don't know if you've heard of this population of people, you probably have. Though we call them super agers because they do well into their 90s and 100s. And research on them is being done to determine what it is about them that enables them to live well throughout their age.
Mhm. I have a great aunt who lived to 106, and she knew the birth dates and the middle names of my children better than I did. And then her sister was 104, and her brother was 107. So I know a few super agers. Yeah,
Yes, yes, so do I. And we probably all do. So it's
sure.
not uncommon.
Mhm.
And, it's going to be an exciting world out there when we discover there's so much research going on, not just with Parkinson's, with dementia, but in aging in general.
Mhm.
What is it that we can do to improve our outcome as we age?
Right. And I think that's so important. That's what we all want to know is what are we doing wrong or what could we be doing better
Right.
to have better cognition as we age, no matter how long we live. Yeah.
Exactly.
So, what does it look like then for people with Parkinson's? Like, what are the symptoms and how do they differ a little bit compared to like normal aging or some of these other kind of umbrella terms? You talked about the umbrella term of dementia. What does it look like for Parkinson's? What are those symptoms?
The symptoms of a beginning of a dementia with someone with Parkinson's disease looks different than, again, normal aging changes. It impacts their ability to function normally, and it's different than someone who has Alzheimer's dementia. Um, some of the things that people will notice or their loved ones will notice is, for instance, they're having more troubles making decisions. So maybe driving is impacted because, you need to make multiple decisions when you're driving. We call this a dysexecutive disorder when they're having trouble with planning, um, uh, judgment, initiation of steps, multiple steps of an activity. So those are the things you may notice initially. Trouble with sequencing tasks. I always try to individualize it with people who I see. And so for men with Parkinson's and the beginning of a dementia, they may have trouble remembering how to start the snowblower or the lawnmower or how do I start the car? Where's the turn signal? Those kinds of things that require multiple steps and memory of previous, your previous memories. Other things that people will notice is inattention, inability to pay attention for, again, trying to, when you're talking to someone, they may not be able to pay attention to all the instructions that
Mhm.
you're given, right? Trouble
Mhm.
focusing.
Mhm.
They have trouble with vision and space relationships. Again, going back to driving, maybe not keeping the car in lane
Mhm.
or not able to park in the space that you need to park into, um, or getting lost or remembering how to get someplace. So someone who has Parkinson's and those things are starting to develop, those are key uh, activities that you should notify their
Mhm.
doctor so they can help you with that. One other thing that is unique to Parkinson's disease with dementia or sort of another condition, we would maybe call it as a spectrum of Parkinson's disease dementia, is Lewy body dementia. Um, One thing unique to these dementias are visual hallucinations that can be there early on. So if your loved one is starting to say things like, I see someone out in the yard and you go and check and there's no one there, that could be a visual hallucination that is going on. That can also start early on. Now,
You're
that
saying that
can,
that's more typical with Lewy body, is what you're saying, correct? Or is that more typical just with Parkinson's disease?
it's more
Mhm.
typical with Lewy body, you're right.
Mhm.
It's more common with Lewy body, but it can also affect people with
Mhm.
Parkinson's disease with dementia.
Okay.
And then that's a good question. How do you discriminate these two conditions?
Mhm.
A lot of effort has gone into trying to classify these two
Mhm.
disorders. Are they really two different things, or are they just the same pathology that happens to start in different places and then spreads to different places? And that's the what I just said is sort of the thinking now is that it's the same pathology. Parkinson's disease with dementia will start in the brainstem, or maybe even years earlier in the gut and spread to the brainstem, and then later on into the brain. Whereas Lewy body dementia can start in the brain itself, resulting in an earlier dementia. The features of Lewy body can also be seen in Parkinson's disease with dementia.
Correct. Good. Yeah, and that's a lot of times people have that question of, is everybody with Parkinson's who has a memory problem, is it a Lewy body dementia? I think there's a lot of gray area there as
Right,
well. Mhm.
right.
What about individuals who have young onset Parkinson's? Is there a difference there in what we see with memory changes, or how do we apply that?
It can happen.
Mhm.
Patients who are young onset with Parkinson's disease, because of their age, are somewhat protected
Mhm.
initially.
Mhm.
But again, as they age with their Parkinson's disease, as again, a 10-year mark, maybe it might not be 10 years, it could be 15 years, but the longer they live with Parkinson's disease, the increase in their risk of developing dementia. So young patients who have Parkinson's disease may not, oftentimes will not have a dementia associated at that time in their disease course, but the longer they live with it, the more the increased likelihood of dementia is present.
And you mentioned before that dementia is an umbrella term and that there are a lot of kind of subtypes here. We've got, Lewy body dementia, a Parkinson's dementia, Alzheimer's disease, and vascular dementia. You can have more than one. I mean, you
Right.
can, so you can have a vascular dementia, which is, has more to do with, and I'll let you explain that a little bit more, plus Parkinson. So it's important to be able to kind of have that checked and discerned. But tell us a little bit more about what some of those differences are.
Right. Probably the most common type of dementia is a mixed dementia. We call
Mhm.
it mixed because you have vascular disease,
Mhm.
but also you have changes of the Alzheimer's type. Um, I think that is actually the most common type of dementia is a mixed dementia. You can have
Mhm.
Alzheimer's dementia and have Parkinson's disease as well, and then dement with Parkinson's disease.
Right.
And so, how would you know? Really, really, you wouldn't know until autopsy. But there are certain features of Alzheimer's dementia where those symptoms are very dominant early on, and those are typically memory and language issues. Forgetfulness, losing things, not being able to find a word, not understanding speech. That's very characteristic for an Alzheimer's picture. Whereas, again, for Parkinson's disease dementia, um, memory and language isn't usually affected early on. It could later on be, but again, it's vision and space, in attention, hallucinations, and executive dysfunction, difficulty with planning and judgment and sequencing of steps.
Mhm. And that can obviously be very troublesome depending on when the person is diagnosed. If it's something that they're diagnosed and they're still working or
Right.
have young family and things like that. So you said that, we really don't have a confirmed pathology until autopsy, but we also do have ways of trying to diagnose it clinically. What are some of those ways that you
Yeah.
use? to diagnose and discern between these different memory disorders?
Well, clinically, you can do neuropsychological testing,
Mhm.
which is a great way to really get into the issues that people are having. Um, it kind of ferrets out exactly what struggles there are, and then you can say, well, it's more likely that this person has this dementing disorder versus this dementing disorder.
Mhm.
We have biomarkers now for both Parkinson's disease with dementia as well as Alzheimer's dementia. What are biomarkers? These are uh, strategies to diagnose the disease without tissue, typically, or image and using imaging studies. So, for instance, in Alzheimer's dementia, we can do PET scanning, and it can diagnose Alzheimer's dementia through PET scanning, tagging amyloid, which is the pathologic protein. There are efforts to do the same with Parkinson's disease dementia. It instead of amyloid, there's a protein called alpha synuclein, and so alpha synuclein PET scanning, we're starting to develop a ligand or that compound that we can use in PET scanning. It's not yet FDA approved or ready for prime time. We can find alpha synuclein in tissues, though. Um, the easiest tissue to grab to try to find Parkinson's disease is actually skin. We can do a skin biopsy, and when we do a skin biopsy, we also find nerves and glands in that skin. And alpha synuclein can also be found in skin and the nerves of the skin if you have Parkinson's disease. So that's one way to aid in the diagnosis of Parkinson's disease. We also have imaging study with a dopamine transporter. We all know when people have Parkinson's disease, they have a dopamine deficiency, and we can measure that using a SPECT scan. So those are additional ways to maybe confirm the diagnosis if clinically it's difficult to tell. And I've done those in numerous patients because sometimes it is confounding. You have different things. You really do want to try to sort this out so you can aim to treat in the best way.
Mhm. And that skin biopsy that you were talking about, the name of that is called a SYN1, SYNONE, SYN1 biopsy that you utilize, correct?
Yes,
Gotcha.
yes.
And then what about like MRIs? Can you tell based on an MRI, or is that not helpful nowadays now that
It's
we have other ways?
it
Mhm.
can be helpful. I think. You really, I would say most neurologists do look at their own imaging
Right,
because they're really focused in on what they're trying to differentiate.
right.
For instance, if you have someone who has Alzheimer's dementia, you will see atrophy or shrinking in parts of the brain, and
Mhm.
you wouldn't see that in a Parkinson's disease with
Right,
dementia. So if you really scour that MRI, you won't probably the radiology report is not likely going to mention that. That's
right.
something you and your neurologist would look at probably together.
So it's more of ruling out other things. It's not necessarily that you'd diagnose Parkinson's or a Parkinson's dementia with an MRI, but you could rule out more of maybe the vascular disease or that
Exactly.
atrophy in other areas.
Exactly.
Super, thank you. And then, so we know that there are, just different tests that you can do. Like, how often do you test people, or how often, if you say those memory tests, how often do you perform memory tests? Is it just something that you do at one time and you have a diagnosis, or is it something you're using for tracking?
Yeah.
Mhm.
I usually try to do a memory test in anyone that I see,
Right,
if they're 60, 65, just to get a baseline.
right,
Even if they're not noticing any memory loss, it's so nice. In 10 years, you can look back and say, here's where you were.
right,
Now here's where you are now. I can't stress that enough. If you have an opportunity that someone is in your office in their 60s, check and a cognitive assessment, just as a baseline. And then you have it to look back to. So in all my Parkinson's patients, I try to do that either the initial visit or the visit thereafter, get a baseline cognitive assessment. And those are typically questions that a tech or I will ask you together. It takes about 10 to 15 minutes of your time. And it's nice to, again, look back at that baseline when things are erupting. The other thing I look at that for, I might do it when driving, the question of driving safety. Uh, there are certain things that you want to look at on that cognitive assessment to consider if they're safe in driving. Those are the vision and space activities on that cognitive assessment. You have to be able to uh, understand where things are and have some vision space relationships that you can't, if you don't have those, clearly you're not safe in driving.
Right. So those tests basically kind of break down functions of the different lobes of the brain. And then you're
Correct.
saying, well, when you're driving and you get all that information in, you're getting a lot of information that you've got to process when you're driving. You can kind of take that person's report or maybe the caregiver's report about what they're saying and possibly put it together with the information that you're getting from that cognitive test.
Correct.
That's
And sometimes based on that, it's enough to say, I don't, I'm not comfortable with you driving based on this. Or if it's not clear, a formal driving assessment can be done through an occupational therapist. And often we'll do that.
sure. Great. And you also use that as kind of a template to say maybe you might need more in-depth neurocognitive testing. So maybe this is just a little snapshot in time of what it
Correct.
looks like. But now maybe you need to see a neuropsychologist to do a longer battery to look at it more in depth.
Right. I would definitely do that if the cognitive assessment in the office isn't helpful. It's not revealing, but yet there clearly are problems functioning
Right.
with, the reports of the family. Yes, neuropsychological testing really gets in there and figures and really is able to sort those things out.
So now you've gotten that back and you know that there is a cognitive issue. How do you go about treating it? What do you do about it? What's the next step for the patient and the family?
It depends on it really depends on what the problems are.
Mhm.
For instance, if it's related to judgment, putting steps in place for making sure fraud and abuse don't occur with phone calls or computers, or really making certain the family's aware of the vulnerabilities of their loved one. Um, if it's related to, again, driving, vision and space issues, it's making sure that maybe they're doing okay during the day when things are bright and light and they can see, but at night they maybe shouldn't be driving because their vision and space is relationships are even worse when you're not seeing things appropriately. Um, there are strategies to improve if someone has hallucinations. The first thing to do is to review that medication list. Are there any medicines that are likely to offend? In other words, are they likely to create problems with cognition or hallucinations? And then paring their medication list down. That's the first thing to do. As people age, they may not need as much medication. Their metabolism slowed down, so you can reduce the dose, or the medication side effects become worse than their benefit, and so you just remove them. There are medications that we borrowed from Alzheimer's dementia. Those are drugs that improve acetylcholine at the receptor site, and they can significantly settle down hallucinations and improve attention and cognition in patients with Parkinson's dementia.
Mhm.
So, you and your doctor would work through those steps, and depending on, the urgency of the situation, um, you would end up, likely on one of those medications that we borrowed from Alzheimer's dementia to try to help alleviate hallucinations or other cognitive problems that they're having.
What about diet? Is there anything that you change or test for diet wise that you could suggest?
Um, you really, because dementia in general has been associated with cerebral vascular disease, you really do try to eat a low fat uh, diet. So to reduce the cerebral or the vascular disease component. Um, some people are on medications for their Parkinson's where you have to worry about cheese and wine and things. Of course, those medications aren't commonly prescribed, but they do need to follow a diet that your doctor would tell you about at the time of initiation of those drugs. Treating any deficiencies of vitamins, for instance, thiamine deficiency or B12 deficiency, which also can create problems with cognition. You want to help other problems, other medical problems that can also contribute to cognitive loss.
Well, I think that's important because anybody that's listening to this might be saying, okay, I might not have any of those problems now, but is there anything I can do, especially when you mentioned before that we know it kind of starts in the gut, right? It might not start right in the brain. If it starts in the gut, what can we do diet wise that could change? And when we're thinking about, vascular, if we can have um, a comorbid, vascular memory issue along with Parkinson's. Like there are things that we can do to change that vasculature, to change the buildup of those cholesterols and things. So there are definitely things that people could be a bit more proactive about. Some oftentimes we wait until it gets there, until we've got a diagnosis, and then we start making suggestions, or we even start listening to those suggestions, right? Maybe the
Yeah,
doctor has told us for years that we shouldn't be drinking as much soda, or we should cut down on our saturated fats. And when we pick our fish fries, we always go for the fried fish as opposed
yeah,
to the baked fish. Are there things, if we're really worried about that we could be doing now to just say, at least I did my best. I did my
right,
best to ward that off,
right.
yeah.
This isn't so much with the literature isn't there yet with Parkinson's disease with dementia, but it definitely is with Alzheimer's. There is a inflammatory component to the dementia, and so if you extrapolate inflammatory conditions,
Uh-huh.
um, potentially, treating your arthritis, or being more aggressive with diet. For instance, if you're a celiac, make sure you really stick with your diet to reduce inflammation in your gut. If you want to treat infections, in the face, head and neck are the most common infections that people have. Not only upper respiratory infections like the cold and flu and things, but also, chronic dental infections or poor dental care. Anything that gives you chronic inflammation could potentially increase your risk of Alzheimer's dementia. So you really maybe even look at yourself system by system and what can you improve to reduce inflammation. Alcohol, we this just made the news because now it's now a carcinogen. I mean, not just now, but we've
Right.
known this for
Yeah.
years.
Yeah.
But now the labeling is going to be changing.
Mhm.
Alcohol is inflammatory, so if you're someone who has an inflammatory condition to begin with, maybe limiting alcohol is a good thing for you.
Absolutely. Do you have a certain diet that you recommend for people who are in your memory clinic?
Yes, that's
Mhm.
good. I would say, especially older individuals, they have a hard time getting enough protein in. And so, maybe initially just thinking about your day's diet and how much protein you got in. And there are online amounts of protein in typical things like an egg or so much of meat, etc. So you can easily try to figure that out, and then try to get your extra protein in dietary wise. So cottage cheese or eggs or beans that, in other words, non-meat or animal protein, more healthy proteins are vegetarian proteins. Um, that's one way, is increase your protein content. The other, again, limit your fats, saturated fats, more healthy fruits and vegetables. If you have frozen fruits and vegetables, great. Fresh fruits and vegetables, great. Really getting more of your diet, trying to shift that from animal to plant-based is really the way to go if you can.
And then what about the role of exercise in memory? How does that relate?
Well, it's the only thing that we know of that can slow the progression of Parkinson's disease and Alzheimer's dementia. We don't have any other, at least for Parkinson's disease modifying therapy. And we've all seen it in our practices. I remember looking back when I was probably seeing patients that after taking care of them for years, noticing these people who are always been exercisers are so much better
Better.
at 10 years off than their sedentary cohorts. There's no doubt.
Mhm.
And so even if you aren't an exerciser, you still can benefit. We know this through research in patients. It's never too late to start.
Mhm.
And
We really noticed it during COVID too, when things shut down, a lot of those groups shut down. Boy, did my patients decline that didn't have a backup plan. It was
exactly.
really, really evident. It is so evident.
Well, and people notice it if they can't get to the gym because they've had surgery or something, an illness. I'm really stiff, I'm tight, I'm slow. I really notice it.
Mhm.
And it's just not at that time when you're exercising, but those are carry over into
Mhm.
hours and hours of time that your movements are so much better.
Mhm.
So definitely, Dacy, and you're a big proponent. I'm a big proponent. Everyone should be a big proponent of exercise. And
Yeah, and
it's
obviously that cardiovascular piece of it is important for our cognitive, our thinking. And we all know that the more sedentary we are and the lower our blood pressure kind of gets, just the more foggy our thinking gets. Mhm.
right. Hmm.
And do you have any tips for either the person who might be dealing with memory problems with Parkinson's or the caregivers that they could utilize at home? I mean, I know there's a lot.
Yeah.
Um, and also, if you have any, I know Julie File works with you and she's got a lot of great programming too. So, where do you kind of go with that?
Yeah, I think the most important thing is to really stay active. Continue with your loved one and doing the things that you love to do together. Just get out there, get out there with your friends, get out, doing new things even, and being socially and physically active. Um, Even learning new things is possible. And that's even very healthy for your brain. We know that it can grow new connections if you're learning new things. Um, don't panic if your loved one is having hallucinations. It's scary, but call your doctor right away. We can help you. Like I said, we need to scour that medication list. Maybe it's time for a medication to start for the hallucinations, but definitely tell your doctor that this is going on so that we can help you. Reach out for support. It's a lonely journey otherwise. Go to support groups or caregiver support groups. You'll find a community that you didn't know was out there, and maybe answers to things that you're struggling with that someone else has come up with a good idea.
Yeah, I think that's one of those people who are dealing more with advanced Parkinson's, especially, or memory issues, the caregivers, I think they feel so much more alone and struggle the most with trying to manage things at home. I have one gal who's I'll give her a good plug here. She's a member of our Nina support group, and she's a caregiver for her husband, and she's amazing. She says, you know what? I just get him in the car and I take him for a ride down to the lake and I put a pole in his hand, even if he doesn't dip it in the water. We just get out every single day,
Yeah.
and I just love her attitude, because you're right. You still need that sunshine. You still need to, and it's something that they're very outdoorsy, and she still gets him out to be who he is. That's who they
Right.
were as a couple, and that's who he is. And she makes sure that even if he's not catching a bunch of fish for dinner, he puts a pole in his hand, and
Right.
they both get out, and they both need that. So
Right.
it's so important to continue being who you are, maybe just in a little different way. What about the future? What about research in this area?
Explosive, I would say. Oh, many studies on many different medications, sometimes drugs that are already available to treat other conditions are now being looked at for Parkinson's disease, and dementia of the Alzheimer's type. So it's a good time to be alive. It's a good time to consider research. If you have Parkinson's disease, maybe go online at the WPA and look at the research studies, and maybe it's something that piques your interest. There's also a long-term study ongoing with the Michael J. Fox Foundation. They're trying to coming up with biomarkers for Parkinson's disease diagnosis. The goal is to diagnose Parkinson's disease even before symptoms arise, because then if we have a medication that is disease modifying, we get people started on it early. Um, could it be a cure to this? This is what we're looking for. So consider research. I would emphasize at any stage of the game, there might be something that you would qualify for and benefit from.
Right. That study you were referring to is PD Generations through the Michael J. Fox Foundation. So if people are wondering what that is, look for PD Generations. So Dr. Kokontis, I thank you so much. If you were to give our listeners one piece of empowering advice, what would it be?
I would say get out there and exercise every day. Do something every day to get physically active. You're helping yourself, you're helping your future. So, whatever it takes to get out there and move, do it. If you need your knees fixed, get your knee fixed. Don't sit around. That's not good for you, and it's not going to be good for your future.
Absolutely. Thank you so much. We appreciate that advice. Thank you all for joining us today. Tune in next month for another episode of Parkinson's EmPower Talks.
Thank you.
The Wisconsin Parkinson Association is a grassroots organization funded by people like you. To support more local programming like this, visit wiparkinson.org.